Please hit record. Thank you.
Awesome. So, hi everyone. I'm glad to see you here on Thanksgiving Eve. Happy Turkey Day. So basically, I'm just going to talk about depression, and I love to hear any questions that you have. So please put them in the chat. We're also going to have a poll a little bit here in a few minutes. So be prepared to answer some questions on the poll and see if we can get everyone going. So next slide. I have no disclosures for today's talk. We're talking again about in the context of the 4 M's, which is the framework for age-friendly health systems. And when we talk about depression, mainly we're looking in the mentation realm, I guess you could say. So we're looking at how depression affects a patient's ability to manage their activities of daily living and function generally as well as they can. So next slide. The learning objectives for today are first to identify what the red flags or the warning signs for depression. We're also going to look at some risk factors for suicidal thoughts and behaviors. We're going to learn about some of the complications associated with untreated depression, and also see how you can help residents diagnose or help your staff basically diagnose depression in your residents. So next slide. So we're going to start off with the poll, and let's see, the first question is going to be, having depressive symptoms is normal when moving to a new environment. I want to see how this is a true false. Having depressive symptoms is normal when moving to a new environment.
So
Well, we do all five.
Yeah.
We'll do all five before we.
Oh, we're going to do all five.
yeah, it's
Okay.
That's how we had it set up.
Okay. All right. So the next question is, the highest risk of depressive symptoms and suicidal ideations occur during the first blank months of moving to a long-term care facility. So there are 3 answers, either 1 month, 4 months, or 7 months. The third question is, feeling down is expected after losing a loved one. And 4, sleep disturbances can cause depression. Answer true, false for 3 and 4. And 5, treatments for major depressive disorders only help some of the time. This is true or false. Okay, now we've got poll answers, and they're pretty spread out. So let's go back.
Yeah.
Can we go back up to the top and we'll discuss these?
Yeah, so I'll give you guys a few
A
seconds.
few more minutes, okay.
Just a few seconds to finish, and then we'll end the poll and share the results. All right.
Some of these are a little tricky.
They are a little tricky.
They are.
Yeah, especially at the beginning of the presentation.
Yeah.
All right, I'm going to end the poll and share the results.
Can you see the results?
Yes.
Everybody out there? Yes. Okay,
All right.
good. So the first one, having depressive symptoms is normal when moving to a new environment. This one, I see 57% true, 43% false. I will agree with the 57% true. It is normal to have some feelings of depression, but what we usually call this an adjustment disorder. So usually you may have some symptoms, but they're not long-term. They don't last for a long period of time. So it's normal to feel down for a little bit. And then as time goes on, usually, technically we look at a 2-week time frame, but it can last longer than 2 weeks, depending on how things are going. So if it's lasting too long, then that's when we become more concerned for depressive symptoms. Next one, the highest risk of depressive symptoms and suicidal ideations occur during the first, let's see, we got 1 month, 4 months equal, 7 months, 14%. And 7 months is actually the correct answer. 7 months.
I have the minority.
Got the one person that got it, so
Yeah.
very good.
Very good. So yes, the first 7 months of moving into a long-term care facility are usually the highest risk for having depression and suicidal ideation. So that's when we have the most concerns. 3, let's see, feeling down is expected after losing a loved one. We got true 100. Yeah, and this is, I think everybody knows that it's expected for some people to have feelings of sadness or loneliness or, emptiness even when you lose someone, especially someone that's been very close to you. So feeling down is expected. When we get a little bit more concerned with depression symptoms if those feelings last a long time, or if the resident is not acting normally, if they're not doing things that they should be doing, like eating or sleeping or functioning. So that's when we get a little bit more concerned about those feelings of sadness. Number 4. This one's really tricky. This is, I think, the trickiest one. Sleep disturbances can cause depression. And we have 71% true, 29% false. So there's a little bit of controversy about this. I would agree with true. Sleep disturbances can definitely cause depressive symptoms. They're one of the major symptoms that we look at when we're, assessing for depression. So a lot of times the sleep disturbance kind of precedes the onset of depressive symptoms. So it's definitely, if someone's having some sleep problems, that can be a sign that it can turn into a depression. So it's very important to look and see that the sleep problems are being followed and the resident adjusts to the new environment. Or it can happen even after the resident has been there for some time. So number 5, let's see, treatments for major depression only help some of the time. We have about half and half, 57 to 43%. So generally speaking, the treatments for depression are pretty good. I would say about 80 to 90% of patients do improve. They may not have complete remission, or those symptoms may not go away completely, but they do have improvement in their symptoms. So there's only a small percentage of patients where they do not improve when they are treated for their depression. And sometimes when I say treatment, that can be a combination of therapy, medications, support. It can be anything, but definitely it helps to get a resident into some kind of treatment if they're having problems with depression. And we'll go into that a little bit more. I've personally, being a psychiatrist, I feel like getting the depression under control early is the key. So that's what we're going to be looking at, is how can we get the depression symptoms better before it gets bad.
If we can answer the question that was just brought up, I think it's a real important distinction, and it affects some of the answers to your poll questions, distinguishing between depressive symptoms and a clinical diagnosis of a major depressive disorder. Can you comment a little bit on that?
Right, Kat, and I'm going to get into that a little bit more during the discussion. When we look at major depressive disorder, it's a constellation of symptoms. So it's several symptoms put together. So you can have a few symptoms and not necessarily have depression. It's when all the symptoms are together that we, classify it as a major depressive disorder. So next slide. we're looking here at red flags for depression. Again, these are some of the symptoms that we're looking at for depression. Typically, at least from what I understand in a nursing home setting, one of the measurements that we use is the PHQ-9. And one of the items, which is item number 9, asks about suicidal thoughts or passive suicidal death wishes. And obviously that would be one of the items that is of major concern. So those are the ones that we really, really have to pay attention to. Interestingly, the way the question is worded is very vague. And so you really have to kind of dig deep and try to figure out what they're meaning by that. It can mean a bunch of different things. So we do know that, answering positively to that item number 9 is definitely one of the biggest indicators or red flags for depression. And then, as I indicated earlier, sleep disturbances, not eating, or weight loss. Weight loss is pretty significant when it comes to depressive symptoms. Having a lot of negative thoughts like, oh, nobody wants to talk to me, nobody cares about me, or it's all my fault. Those are very typical types of symptoms that we see. Changes in behaviors. This one's really important. So a lot of patients will say, I used to be able to do these things and now I don't feel like I want to. I don't want to go out and talk to my friends. I don't want to talk to anyone, or, I just don't have that desire. So that would be an indication of depression. Also changes in their focus or concentration and short-term memory problems. These symptoms can be a little bit more severe and they can also look like dementia. So whenever we have changes in concentration or short-term memory, that is very indicative of having, more severe type of symptoms. And then changes in self-care, not wanting to take care of themselves, or not not being interested in things that normally give them pleasure. So that could be hobbies, it could be anything really that normally gives them feelings of joy, but they say, I just don't think it doesn't make me feel good anymore. So those are some red flags, and definitely concern for further evaluation. So next, this is kind of a busy slide, but I think it's a very important slide as far as assessing for suicide. And we know that as patients get older, and depression symptoms tend to also get worse. So looking for these suicidal thoughts is extremely important. And oftentimes, patients are a little bit, or residents, they can be a little hesitant to describe having these thoughts. So you sometimes have to probe. One of the things I found out while doing research for this talk was that there is a higher incidence of suicidal thoughts in nursing homes that have a higher ratio of staff to resident, which is interesting because you would think it would be decreased, but in actuality it's increased. And I think part of that is because there are more people to ask these questions. So that kind of results in having, a higher incidence, or more finding out more about what the thoughts are actually happening in the resident's mind. So looking at some statistics, these are some suicide statistics from the CDC website. In 2007, there was a prevalence of suicide in the older population. I believe it was 65 and up. It was 14.3 events per 100,000 people. And that's almost double the rate of a younger population. So it's very significant. Males account for 79% of all suicides. So there's definitely a higher risk in males compared to females. In 2007, the suicide rate for men was 75 years and older was 35.7 events per 100,000 people, which is almost twice the rate of men for all other ages. So again, very high rate for men. Among women, the incidence of suicide peaks about ages 45 to 54. So it's a little bit lower in the older age group, but it's still about 8.4 per 100,000. About 55% of suicides occur by firearms. So having a weapon is very high risk in patients who have severe suicidal ideations. And then suicide risk increases about 67% after any prior incident of self-harm. So, you know, if there's any person who's had a prior suicide attempt, that definitely is a big red flag. Also, history of depression, it would be another big flag for suicide. So those are some of the ones that are the most important. Of course, anytime there's any medical concerns, either pain or polypharmacy, can probably attest to that. Those would definitely be higher risk. If there's any disability, like especially residents who were previously employed, and that may turn into some financial problems, that can also be a risk factor. Let's see, some personality issues can be risk factors. You know, those are the ones that I deal with quite a lot. And then substance abuse is a big one. If there's any history of substance abuse, that can increase risk significantly. As far as protective factors, you know, of course, having a good support network, being married, having children who are involved, a sense of optimism or hope, and then I put diagnosis of dementia or cognitive impairment. This is a little bit tricky because early in the diagnosis, the risk of suicide is actually higher, but as the dementia progresses, it seems to decrease significantly. So that can go either way. Do you see on the chat?
The questions about religion, if that's protective, you know, having a
Yes.
faith base.
Yes, but you know, that would kind of go into the sense of optimism and hope, and
that could encompass that religious base for being a protective factor.
Exactly. So definitely religion, and plus, you know, a lot of religious communities have a support network in place, so that kind of helps the resident with feeling like they're not alone. And was there another question before that?
No, that was
okay. Got it. All right, so next slide. We're talking about another complication of depression. This is, well, let me go back. Hallucinations aren't always a complication of depression. They can be related to other conditions, but I wanted to go over hallucinations because they can be a complication of severe depression. So, and just to explain what hallucinations are for people that don't know, they're perceptual disturbances. So you can have seeing things that are other people don't see, hearing things that other people don't hear, tasting things, feeling sensations like creepy crawly feelings on their skin, or sometimes tension feelings along their head, and then smelling things. The seeing things and the smelling and feeling things typically are more suggestive of an organic brain process. Not always, but they can be. Hearing things can be more suggestive of a psychiatric disorder. We also, with the creepy crawly feelings, a lot of times we see those with drug withdrawals. So that can also be a symptom of maybe a drug problem. But one important thing to note is that hallucinations can occur in healthy populations. And it's thought that maybe some overstimulation can be related to hallucinations. After, I see this actually quite frequently after people have gone through a loss, they can have some hallucinations of either hearing or seeing their loved one. And a lot of times this is like a comfort to them. They feel like the person's with them or helping them. And those are pretty normal. I think where it becomes more of an issue is where if the hallucinations are distressing for the patient, a lot of times that's where we have to be, they might be associated more with the depression. Any type of distress can cause hallucinations. Also, sleep disturbances are a big cause of hallucinations. So if, especially if they're going on for an extended period of time, that can be a symptom. And then, of course, poor cognitive function can give patients a higher likelihood of having hallucinations. So I would, say that if a resident is having hallucinations and they haven't had a loved one die recently, or there isn't a specific cause that is known, that would definitely be a reason for sending to evaluate for a more severe type of problem going on. A lot of times the hallucinations can be very disturbing to the family members, more so to the patients or the residents. So, that's another thing that I guess, it's important to kind of let them know that it's just symptom. It's not necessarily always a bad thing. And it's just something that needs to be evaluated. All right, so we're kind of getting to the complications. We talked about severe memory loss. We talked about increase in substance use. A lot of times that untreated depression can cause residents to resort to other substances. And this can be also in the form of prescription medications. So it's something to be aware of. They might rely more on prescriptions when they don't need to. They can also, the overuse of medications can also lead to more physical problems like falls. So it's important to have them evaluated. And then isolation is a big complication over time that can also lead to more physical health problems. And then the most severe would be depression, suicide, and then more aggressive type of symptoms. So it's definitely, don't want to let the depression get to the point where it's so severe that the resident isn't functioning well. Next. So in terms of evaluation of suicide, the most common, or when we look at risk, we're looking at risk factors, and we're also looking at what is the resident saying at that particular moment. Are they saying, and you have to, kind of dig a little bit deeper to understand what their concerns are. It might be just a concern about dying in general, not necessarily like I want to die right now, but or maybe even a fear of dying. So, trying to figure out exactly what their concerns are. If they do have thoughts like life is not worth living, that definitely requires further evaluation. If they have active suicidal thoughts, if they say, yeah, I want to die, like I don't really want to live anymore, then that requires more immediate evaluation. They may not have a specific plan. They may not say, I'm going to do it, like I know how I'm going to do it, or I'm going to do it today or tomorrow, but it may be more like, yes, I just don't want to live anymore. And then the most severe type of evaluation that requires immediate attention or emergency room is, yes, I have a plan and I want to do it right now. And so believe it or not, I've had several patients who, and it's not uncommon for patients to voice that. So if they do say it, take it seriously. It's not something to be taken lightly. This is just a resource for nursing homes. The first one is through the SAMHSA website. It's a, I don't know if we can put the link in the chat, but they have like primers. They're actually really excellent for nursing homes and to give to patients or residents and family members on what to do, how to take care of depression, and what are the signs and symptoms of depression, things of that nature. And then there's the suicide hotline, which is important to have on hand. And that way residents can call if they need to, or if they're able to. I don't know, some may not be able to, but those are nice resources.
We will be sharing these out in post-session email.
Okay, and let's see, next takeaways. So the final, when we look at depression, we want to take into account, of course, the whole constellation of symptoms and what's going on. We want to make sure that even if they're having other problems going on, such as, loss or loneliness, that we make sure that the depression isn't making it worse. So, for example, with the pandemic right now, we're seeing a lot of issues with social isolation and loneliness. And that just, for patients that already have depression, that just magnifies the depression. So we want to consider that when we're taking care of their emotional needs. And then we also talked about how depression and suicide risk increase with age. So that's an important take home. We want to address the factors that may increase risk and also assess for depression regularly. I know it can, they may not be depressed at one time, and then another, could be several months later, the depression sneaking in, especially now with the pandemic. It's such a huge issue. I think it's important to have multiple assessments, and CNAs can do a really good job of it, I think. So, training in that area is important. It's important to note that depression is treatable and can be very helpful in improving quality of life for the residents. So please, if you feel like someone needs help, please get them at least evaluated by your primary care doctor or psychiatrist. And then also more than 25, this is a statistic that I found, more than 25% of nursing homes have difficulty in assessing residents for emotional problems. And then 45% feel like they are unable to provide the needed crisis interventions. And 33% feel that they cannot coordinate with community providers. So we really want to change these statistics. We want to make sure that those people who need help can get the help when they need it, and that you have the resources you need to get them the help that they need. So if you have any questions, please put them in the chat. And those are the references that I used.
Thank you very much. We'll be sharing the slides out with the participants and the web resource.